for you, David, if you are ready to go.
Sure, let's go ahead and get started.
Can you see that okay?
That's perfect. Thank you so much. So I'll be speaking this morning about COVID-19 vaccination. I'll give a bit of an update. A lot changed over the past couple of weeks. So hopefully this will be of interest to folks. I'll start with a bit of an introduction. Then I'll talk about current vaccines and recommendations for use. We'll talk about safety and effectiveness, a bit about misinformation and improving vaccine confidence, and then we'll wrap up and see if there are any questions. So next slide. So I wanted to start out just by saying that vaccination is the best way to build protection against COVID-19. It's out there that people should just let themselves get sick and get immune that way. But that is not the best strategy. The most obvious reason why that's a bad strategy is because it exposes people to the risks of COVID-19, which everybody is familiar with. You know, severe illness, long COVID afterwards. Getting vaccinated gives you immunity, and it avoids the risks of actually getting COVID-19. The other issue with relying on infection to becoming immune is that the level of immunity is variable depending on things like severity of illness. So really vaccination is the best way. So I just wanted to start with that. I think everybody here will agree with that. Next slide. So what you can see here are the currently, what you can see here is that we're well into vaccinating the US population. So really at the beginning of last week, almost 194 million people were fully vaccinated, and we'll talk about what that means. About 86% of the population more than 65 years old. At that point, about 68% of the population more than 12 years old. So we're well into vaccinating the US population, but we have a ways to go. Next slide. So this slide shows that even though we've come a far way in vaccinating everybody in the US, there are real variations between different parts of the country in how much vaccination there's been. And you can see the darker blue are the areas where there's been a larger proportion of the population vaccinated. The lighter color is lesser proportion. Unfortunately, us in West Virginia, we're one of the groups that are lesser vaccinated. So we have a lot of work to do. Next slide. So these are the vaccines that have been approved or authorized for folks who are 12 years and older. And I'll run down. In that first column are the different vaccines. So the first one is Pfizer, or Comirnaty is the brand name. That's an mRNA vaccine. So it's FDA authorized for folks who are 12 to 17 years old, 2 doses, 21 days apart. And we'll talk a little bit more about this later in the talk, but people who are immunocompromised, who might have trouble responding to the normal primary series, can get an additional dose at 28 days or later after the primary series. It is fully FDA approved for people who are 18 and older, and again, the same dose schedule. Moderna is also an mRNA vaccine, 2 doses, 28 days apart. And again, for folks who are immunocompromised, they can get an additional dose at 28 days after the first dose. The Janssen or Johnson & Johnson vaccine is a viral vector vaccine, and it's a single dose for the primary series. And we'll talk a little bit more about this later, but it's currently recommended that everybody who got vaccinated with Johnson & Johnson get a booster at least 2 months after the primary series. In terms of the mRNA vaccines, we'll talk about boosters for those later in the talk. Next slide. So one of the new things that happened at this point about a week and a half ago is that the FDA authorized the Pfizer vaccine for the age group 5 to 11. They get a smaller dose than older folks. They get a 10 microgram dose instead of the 30 microgram dose that's used for older doses for older folks. And it's the same dose schedule. It's 2 doses, 21 days apart. Next slide. So the mRNA vaccines, the way that they work is mRNA is the molecule that tells your cells how to make proteins. And so what's in the vaccine is the vaccine is made of mRNA that encodes for the SARS-CoV-2 spike protein. SARS-CoV-2 is the virus that causes COVID-19. You can see the picture over on the left with the little red spikes that stick out. That's what allows the virus to stick to cells and infect them. So the vaccine is made of mRNA that encodes for the spike protein. And so in terms of how it works, when it gets injected into your arm, it gets picked up by muscle cells, and they use that mRNA to make spike protein. And then your body makes an immune response against the spike protein, including antibodies and T cells. And then when you get re-exposed to the SARS-CoV-2, you're protected against it. Next slide. So the Johnson & Johnson viral vector vaccine, the way it works is it's an adenovirus that's been engineered to be non-replicating, so it can't cause infection. And what is done is DNA that codes for the spike protein is put into that non-replicating virus. The virus is injected into your arm. It gets into muscle cells just like any other kind of virus would. Again, your muscle cells make the spike protein and you make an immune response against it. In both cases, both the mRNA vaccines and the adenoviral vector vaccines, the genetic material that's injected does not hang around. It is gone and it doesn't affect the host DNA at all. Next slide. So in terms of recommendations for vaccination, as of last week, COVID-19 vaccination is recommended for everybody 5 years and older. Remember that FDA authorized the Pfizer vaccine for folks 5 to 11. And this includes people with underlying medical conditions, people with immunocompromising conditions, people with a history of SARS-CoV-2 infection, and folks who are pregnant, lactating, trying to get pregnant, or might become pregnant in the future. And I'll expand on that on the next slide. So let's go to the next slide. Next slide. Thank you. So COVID-19 vaccination is really important during pregnancy because folks who are pregnant are more likely to get severely ill from COVID-19 than non-pregnant people. So being pregnant is an immunosuppressed sort of state to allow the fetus to develop. And unfortunately, that also makes folks who are pregnant more susceptible to getting severe COVID-19 if they get infection. So people who are pregnant really need to be protected. There's no evidence that any of the COVID-19 vaccines affect current or future fertility. They don't cause infection in the pregnant person or fetus. There have been no safety concerns from animal studies. There's reassuring safety data. I mean, we've now given the vaccine to millions and millions and millions of people. And the data suggests that mRNA COVID-19 vaccines during pregnancy are effective. So people who are pregnant need to be protected and the vaccine is safe and effective. Next slide. So after vaccination, folks are considered fully vaccinated 2 weeks after their second dose in a 2-dose series, or 2 weeks after a single dose in a single dose with the J&J vaccine. And people who are fully vaccinated can participate in many of the activities that they did before the pandemic. However, to reduce the risk of being infected with the highly infectious Delta variant and possibly spreading it to others, people who are fully vaccinated should wear a mask indoors in public if they're in an area of substantial or high transmission. So if you're somewhere where there's a lot of transmission going on and you're inside with other people, wear a mask, because it just makes sense that the more things you do to protect yourself from infection, the better off you are. People who are fully vaccinated might choose to wear a mask regardless of the level of transmission in the community if they're at increased risk for severe disease, or if they have somebody at home who's at increased risk for severe disease or is unvaccinated. Next slide. People who are fully vaccinated may resume domestic travel and refrain from testing before or after travel, and from self-quarantine after travel. They can refrain from testing before leaving the US for international travel unless a test is required for the destination. And they can refrain from self-quarantine after going back to the US. And they can refrain from routine testing, screening testing, if feasible. And for more information, there's a lot of information on the CDC website. Next slide. So now we'll talk a little bit more about the additional and booster doses of COVID-19 vaccines. And this is something that's evolved over the last few weeks even. So an additional dose after an initial primary vaccine series, in terms of what that means, is that's an extra vaccine dose that can be administered if someone is in a group where they're immunocompromised and the primary series might not give them enough immunity. And that's that 28-day dose that I talked about. A booster dose is administered when the initial sufficient immune response to a primary vaccine series is likely to have waned over time. So if you give the primary series to somebody that has normal immunity and they initially make a response, it's going to wane over time. And there are recommendations for giving a booster dose, and we'll expand on that. Next slide. So these are some of the groups that might get an extra dose of the mRNA vaccine at 28 days or later after the primary series because of concerns that they might not respond. So if somebody's receiving active cancer treatment, if somebody's received an organ transplant and they're on immune suppressive medications, or got a stem cell transplant, if somebody has moderate or severe primary immunodeficiency, like congenital immunodeficiencies, if someone has advanced or untreated HIV infection, and if someone is receiving active treatment with immunosuppressives for diseases like autoimmune diseases, folks like that should get an additional dose of the mRNA vaccine after their primary series, again, 28 days or later. And in this additional dose would be the same type of vaccine as they got with the primary series. Next slide. And then here are the folks who should receive a vaccine booster dose. And this may evolve. There's been stuff in the news recently that Pfizer is asking for approval for everybody 18 years and older to get a booster dose, but that hasn't happened yet. At this point, the recommendation for folks who should receive a vaccine booster dose are folks who are 65 years and older, folks who are 50 to 64 years with underlying medical conditions, and that could include some of our pulmonary conditions like COPD, or 18 years and older who live in long-term care settings. All those folks should receive a booster dose. In addition, like I said earlier, folks who are 18 years and older who got Johnson & Johnson as their primary vaccine, they should get a booster shot at least 2 months after that primary vaccine. For the mRNA ones, it's 6 months and more. Next slide. In terms of vaccine dose eligibility, I just told you who is recommended should get a booster, but the actual group of folks who are eligible to get a booster is broader than that. So again, 65 years and older, they should, 18 and more who live in long-term care settings. Remember, I said before that the recommendation for who should get a booster if they have an underlying medical condition are folks who are 50 to 64, but actually people who are 18 and older are eligible to get a booster if they want to after consulting with their physician. And also folks 18 and older who work or live in high-risk settings. For example, folks who work in healthcare, folks who perhaps live and work in settings where there have been outbreaks, like poultry processing, those folks are also eligible for boosters. And then you get the booster 6 months after your second shot. And in terms of which booster you should get, if you received, no matter what you received as your primary vaccine, you can get any of the COVID-19 vaccines authorized or approved in the U.S. as your booster. So if you got Pfizer, you can have a booster with Moderna or J&J, or any, you can get anything for your booster. That's a difference from the additional dose. And then if you receive the J&J as your primary vaccine, again, you're eligible for booster if you're 18 years and older. And everybody who's 18 years and older who got the J&J really should get a booster at 2 months or more after their primary shot. Okay, next slide. And like I talked about before, for the folks who are 18 to 49 with underlying medical conditions, or folks who are 18 or more and work or live in high-risk settings, you have the option for individual risk assessment. People should consult with their physician and make their decision about whether they want to be vaccinated or not. Next slide. If they want to be boosted or not. I'm sorry. So I'd be remiss if I didn't say something about OSHA's emergency temporary standard on vaccination and testing. And this is directly from the OSHA website. So employers with 100 employees or more under this emergency temporary standard would be required to ensure that all workers are fully vaccinated unless the employer requires unvaccinated employees to undergo weekly testing and wear a face covering. Next slide. And the other part to it is covered employers must provide paid time for workers to get the COVID-19 vaccine or recover from any side effects from having the vaccine. So this emergency temporary standard has been challenged in court. There's been an injunction against it, and so this has stayed, and we're not sure when or if this will happen. But I thought folks would want to know about it. Also, in healthcare, CMS has established a requirement for facilities that participate, that they get reimbursement from CMS to vaccinate their workers. And they don't, one difference between that and the OSHA standard is they don't have the part about folks who are unvaccinated getting tested weekly wearing masks. They're simply requiring vaccination, although they do allow exemptions for religious reasons or for medical reasons. And I believe that the January 4 is the deadline for that. Next slide. So now I'm going to switch gears and talk a little bit about safety and effectiveness of COVID-19 vaccines. And they are safe and they're effective. And safety has been a top priority from the very beginning. And before the vaccines were even authorized, FDA reviewed safety data from really large clinical trials. And the Advisory Committee for Immunization Practices, which is a committee that advises CDC on how vaccines should be used, also reviewed safety data. So even before the vaccines were authorized, they were really intensively studied and the data was carefully reviewed. And then since authorization, now we've had the vaccine, if you've seen, given to millions and millions of folks. FDA and CDC have continued to closely monitor vaccine safety and side effects. And there are strong systems in place that have allowed tracking for safety issues. So, for example, there's the Vaccine Adverse Event Reporting System, or VAERS, where patients or their providers or family members, they can report serious adverse reactions of concern to CDC, and those can be investigated. There's the VSafe smartphone program that folks can put on their phone after they're vaccinated and report adverse events. So a lot's been done. Next slide. And in addition to VSafe and VAERS, which we just talked about, CDC has the Clinical Immunization Safety Assessment Project, where clinicians can report adverse events to CDC and get consults and discuss individual cases with CDC. Data is available from the VA. And then in addition, a large databases have been monitored of patients. For example, CDC has the Vaccine Safety Data Link, or the VSD. You can see over on the right side here, which is a partnership with a number of healthcare systems to track adverse events. The VA and DoD are tracking things. FDA is tracking things. So really, the vaccines are being very carefully tracked for safety issues. Next slide. So there are some things that commonly occur after you get your COVID-19 vaccine. And some of the things that commonly occur are mild to moderate, to occur within the first couple of days of vaccination, then resolve. On the arm where you get the shot, it's very common to get pain, redness, swelling. It's very common after getting the shot the next day or two. They have tiredness or headache or muscle pain. Some folks can get chills, fever, even nausea. Those things pass. Next slide. Serious safety problems are really pretty rare. And so, for example, anaphylaxis, which is a severe allergic reaction, only about 2 to 5 people per million vaccinated in the US had anaphylaxis. There's something called thrombosis with thrombocytopenia syndrome, blood clots with low platelets. Primarily occurs after the Janssen COVID-19 vaccine, primarily in women 50 years or less. As of October 6th, there were 47 confirmed reports after more than 15 million doses. So really pretty rare. Myocarditis and pericarditis. That's inflammation of the heart and its lining, the pericardium. Most of the cases of this have been reported after the mRNA COVID-19 vaccination. It mostly occurs among people 30 and younger, especially male adolescents and young adults. As of October 6th, there were 1,640 reports among folks 30 and younger. As of September 20th, a little bit earlier than that, there have been almost 25 million doses in that age range. So again, these things happen, but they're really rare. And this really speaks to the intensity of the safety monitoring that's been going on to really understand these things. And safety monitoring continues to go on. And even though these things may sound scary, the risk of these is way less than the risk of getting COVID-19 and having all the bad things that can happen after COVID-19. Next slide. So vaccine effectiveness, especially against severe disease, has been really good. So here's a plot that shows vaccine effectiveness against COVID-19 associated hospitalization. And these are several patient cohorts that have been followed over time. And you can see in terms of protecting against disease that's serious enough to land you in the hospital, vaccine effectiveness has been well maintained over time. Next slide. This is a study that came from 21 US hospitals in 18 states, covering the period from March 11th to August 15th of this year. And it breaks out effectiveness according to the different types of vaccines. So over that full surveillance period for Moderna, the vaccine effectiveness was 93%. For Pfizer BioNTech, the vaccine effectiveness was 88%. And for Johnson & Johnson, the vaccine effectiveness was 71%. So all of these were pretty good effectiveness. The Johnson & Johnson was a little bit lower though, and that's part of the reason for the recommendation that everybody who had Johnson & Johnson as their primary should get a booster at 2 months or more after Johnson & Johnson. And remember, the booster can be with any of the 3 approved or authorized vaccines. Next slide. So this is vaccine effectiveness against just getting infection. So recall I showed you earlier vaccine effectiveness against getting infection severe enough to go to the hospital. This is vaccine effectiveness against just getting infection. And as you can see over time, the vaccine effectiveness against just getting infection has waned some. And there are two things that are going on here that it's kind of hard to separate what's going on. One is that time has gone on, and perhaps vaccine effectiveness has waned over time. Perhaps antibody levels have dropped, and people are a little bit more susceptible. And then the other thing that's happened is in late May, the highly infectious Delta variant that is the main type of SARS-CoV-2 that's out there now only was 7% of infections. But by July 31, it was 96% of infections. So part of it may be waning of immunity, and part of it may be the spread of the Delta variant. Next slide. And this graph shows the amount of different variants that were circulating among cases in the US weekly going back to July. And as the orange bar is the proportion that are Delta variant. And as you can see, as of last week, the Delta variant was more than 99% of the, it accounted for more than 99% of the COVID-19 cases in the country. So really, we're pretty much dealing with Delta variant now, as opposed to the earlier variants that were circulating before. Next slide. So even with Delta variant, you're still way better off to be vaccinated than not to be vaccinated. And this is data from 13 US jurisdictions covering the period from April 4 to July 17. And you can see the three graphs here. The one on the far left are just being infected, the incidence rates of infected, vaccinated and unvaccinated. In the middle is getting infections enough to result in hospitalizations. And on the right is incidence of mortality. And the blue line is folks who are fully vaccinated. The black line are folks that aren't fully vaccinated. The vertical blue lines are the point in time when Delta became more than 50% of the cases in the country. And as you can see in the graph on the far left, the incidence rate in folks who were fully vaccinated was 4.6-fold lower than folks who weren't fully vaccinated. In the middle, for hospitalizations, a 10.4-fold reduction in folks who were fully vaccinated. And in the graph on the right, an 11.3-fold reduction in folks who are fully vaccinated. So you're way better off being vaccinated than not vaccinated, even with the Delta variant. And your protection against serious infection is better than your protection against getting an infection, but you're still way less likely to get infected if you're vaccinated. Next slide. So now I'm going to switch gears a little bit, talk about medical misinformation and vaccine confidence. And misinformation is false or misleading information that's shared without the intent to do harm. And there was a US Surgeon General report earlier in the year confronting health misinformation. And I'm going to read you a quote from that just below the image of the report. In recent years, the rapidly changing information environment has made it easier for misinformation to spread at unprecedented speed and scale. And that's partially due to the modern information environment. Really, in social media, there are incentives for engagement over accuracy. And the prioritization of algorithms, for popularity and previously viewed content, relate to a level of engagement. And things are there pretty much, forever. So really the priority for spreading information is people being engaged with it and excited about it, not whether it's accurate or not. And that's not only true for misinformation, that's true for disinformation, which is false information deliberately created and disseminated. So a lot of folks who are getting their information from sources like social media are getting misinformed. Next slide. So here are some of the common myths that are out there that are wrong. COVID-19 vaccines make me sick with the virus that causes COVID-19. And that's obviously false. COVID-19 vaccines affect fertility in men and women. That's false. COVID-19 vaccines cause me to test positive for COVID-19 on a viral test. That's false. COVID-19 vaccine alters my DNA. That's false. But people read these things and they believe them, and it's unfortunate. Next slide. So to combat that, we need to build vaccine confidence, and vaccine confidence is trust that folks have in the vaccines and in the providers who administer the vaccines and in the policies and processes that brought the vaccines to folks. Next slide. So here are 6 ways to help build COVID-19 vaccine confidence. One is to encourage leaders and family community organizations to be vaccine champions, have discussions with friends and family about vaccination, understand folks' perspectives and don't be judgmental, but to the extent possible, encourage the decision to vaccinate. Share key messages that promote action through trusted channels that people believe in. Help educate people about COVID-19 vaccines, including how they were developed, their intense safety monitoring, and how you can talk to others about the vaccines. Again, really important to be non-judgmental, not confrontational, understand where people are coming from, try to help them, move them if you can, and if you can't, you can't. Learn about finding credible vaccine information. When you come across COVID-19 information, go to cdc.gov, but you can cross-check and see if it's true or if it's misinformation. And make your decision to get vaccinated visible and celebrate it. Next slide. And again, the CDC website is a great source of information about vaccination. There's material for patients, there's material for providers, there's material for employers. So really strongly recommend it. So I'll wrap up there and take any questions. And I guess I'll pop open the chat. So we had a question from Charles. Is there any reason the vaccine would deter from obtaining tests such as mammograms? There have been reports where people got the shot in their arm and it caused lymphadenopathy, on that side. And then that got, picked up and, on mammograms, and it caused concern. So if you can get the mammogram before being vaccinated or wait a period of time after being vaccinated, that's probably best. But that's the issue, and you can understand that. You have an immune reaction, you get some lymphadenopathy. And then I don't see any other questions in chat.
Dr. Weissman?
Yeah.
I have a question. This is Lisa Emery at New River Health Association. We have our pulmonary rehab program, our Grace Andorni pulmonary rehabilitation program, and we're also a Black lung clinic. And a lot of my coal miners will not get vaccinated. And so when they say this technology hasn't been around long enough, what are some things? And I had a patient that showed up way early, like 2 hours early just now. So I apologize if I missed something. What is a good spiel that I can share with them to convince them that it's safe to take? It's like beating your head against the wall.
Yeah, and it's really unfortunate because people who have lung disease, obviously, if you get pneumonia from COVID-19 on top of your lung disease, you're at increased risk, right? I mean, if you're marginal in your gas exchange to begin with, and you get that. So one thing is to emphasize on folks that, you're at increased risk. If anybody needs to be protected, it's you. And then the other thing is, even though the COVID-19 vaccine is the first mRNA vaccine that's been, licensed and authorized, to be used, the technology's been around for a long time, and it's been intensively studied for more than a decade. So it's not like this is like out of the blue, that there was no foundation for it. It's like I say, it's just really unfortunate. I mean, the other thing I would say is that we're in a different place now than we were when the vaccines first came out. Like I showed, like early in the talk, basically like 190 million, like I think it was 186 million as of the beginning of last week, folks were fully immunized, most of them with the mRNA vaccines. So there's a huge amount of experience now, probably more than any other vaccine, given how closely it's been followed. So I think that's what I would say to folks, and I understand where you're coming from, but you have to understand medically, you're making a bad decision.
Right. Is there an example of the technology that it's been used in before that I could try and, hand that to them?
Yeah, I think there's there've been a lot of animal studies, that have been done, over time, and non-human primate stuff. Again, it hasn't been used in people, but it's been used in people now for really, since, really that the trial started in the middle of last year, and so, and more than 100 million people. I mean, to me, there's nothing that came before that would match the experience we've had since then.
Okay,
We're
thank you.
That's what I would emphasize, is we're in a different place now than we were maybe in December when you started thinking about this.
Right. Okay.
This is Dan. I see, Mary, I came late. I'm sorry. So I didn't hear the introductions and I missed your first few slides, Dr. Weissman. But I know Mary Otto introduced herself, I'm sure, and I see her shaking her head. And Mary, as a person who does some popularization and explaining, I saw you shaking your head when Dr. Weissman was responding to Lisa's questions. As a journalist and an explainer, how would you answer Lisa's question, taking advantage of Dr. Weissman's science?
I was listening so carefully to him as a good model for someone who can translate, this complex scientific information and all this data into useful forms for, say, a coal miner who's very technically and mechanically minded. And I love the way Lisa asked her question about how has this technology been used? Like, let's talk about this in mechanical terms that people can really grasp and embrace. And the way he answered it, I thought was very strong. This has been, 100 million people, 180 million. Most of them have had this. This is in a different place than it was when you might have started thinking about this earlier in the year. Those are things that people can really grasp, and they're very practical ways of thinking about it, I thought.
How about, Lisa and David, how about the vaccine is the long wall of, is the long wall of vaccination. But with metaphors, you have to watch out, because sometimes metaphors can backfire, and miners know that long wall has its own problems. But generally, we pick a metaphor that brings a new thing into connection with something in the person's familiar environment. So I'm not sure that's the metaphor here, but the idea would be you have good experience with trying things that are new. I think your point about miners being sophisticated mechanically and technically is a really good one, Mary. But I've heard that one a lot as well, and I'm glad Lisa brought it up. And in terms of Dr. Weissman's point about not being judgmental in doing these explanations, that's really, really hard for us. But I think he's right. Generally, when I'm seeing miners in our Black Lung Clinic who come in, and we basically won't let people in for pulmonary rehab if they're not vaccinated. That's a firm limit for us at both New River and Cabin Creek. But we do OP exams on miners without discriminating based on vaccination. We ask them, and generally what I do is just thank the ones who are vaccinated and said that really helps us, and they do understand about workplace safety.
We have a nice comment in chat that mRNA vaccines have been studied in early stage clinical trials also for other diseases such as influenza, Ebola, Zika, and rabies. So thank you to Santa for posting that.
Another question, just because I'm trying to, I've got you guys here. What do you tell people who won't get the booster because they had such a bad reaction to their second shot? I know a few people like that. They're just not wanting to do it because they were sick for days. And would possibly rather get their antibodies tested. I'm just throwing all these things out there.
Yeah, well, I mean,
need
the
help.
problem with getting antibody testing is that there isn't a known level of antibodies that's protective, you know, and probably the best antibody testing would be what's called neutralization testing, where you actually look at the ability to prevent infection of cells, but that's not generally available. So with the ELISA, so with the types of antibody testing that's out there, you know, that people can generally, you know, get to, you know, that's not really recommended as a way to look to see if people are protected, you know, at this point. I guess if somebody had a really bad reaction to, you know, one type of vaccine, you know, you could, you know, booster them with a different, with a different vaccine now, you know, since it's now, you know, recommended that you can, you know, that you can mix things. And again, at the current time, you know, there's certain groups that are recommended who should get the booster, you know, so if the person is in a group that should get the booster, you know, I would push a little bit harder to, you know, to try to convince them to accept it than if they're, you know, in a group who may get a booster.
Thank you. I appreciate you.
Thank you so much. Oh,
Lisa
Dr. Doyle?
Lisa and I have a case. We didn't submit it. We don't have pictures, but it is relevant to this. But that's just to put on, well, it's 8:44. But I want to wait and see if people have other, and Lisa, it's going to be DL, our young guy who has the really bad CT that you and I just saw this week. That would be the case. But anyway, I'm curious if there are any other questions for Dr. Weissman. This was so interesting.
That was a wonderful presentation. Thank you so much. And yeah, please, any questions, you can chat them in, use the raise hand feature. This is something that's always evolving, but that was really good in the chat saying that mRNA has been studied a lot and through animals, and a lot of our diseases are going to be zoonotic.
So I guess one last final comment is we're into flu season now. People can get their COVID vaccine and their flu vaccine at the same time. So, you know, if folks need their primary series or if they need to be boosted, they can get their flu at the same time.
You know, in some ways, I think there's never, in my whole, you know, people say, you know, and when you come to West Virginia from outside, people say, you're not from around here, are you? You know, and you kind of just sort of take that with a grain of salt and move on. And in my 43 years living in West Virginia, way more than half my life, there's possibly never been a better example when a small number of people can make a significant difference. Because, and the thing that makes me sad, we've been visiting our son in the Bay Area, Oakland, California, across from San Francisco for the past month, and feel like I've gone from one extreme to another in terms of awareness and public acceptance of both vaccine and social distancing and science. I mean, it's remarkable here that almost nobody on the bus, on the subway, almost nobody is unmasked. Yesterday, we went to a musical play, My Fair Lady, in downtown San Francisco, and it was almost packed. you had to show your vaccine evidence. You had to show your CDC vaccine card before they let you in the door, and nobody was pitching a fit or complaining. So it's really remarkable to, and the comparative incidence of new infections, I haven't checked West Virginia this week, but last week it was running around 47, 45, 47. For weeks here, it's been around 5.
Wow.
From a much more densely populated region, and with plenty of people living in very crowded, cramped conditions. My 6-year-old grandson is in kindergarten. I walk to school with him most mornings. Everybody, including all the kids, are wearing masks. Last week, he came down with a runny nose and cough, but no fever. And his mom tested at home and he was negative. That was a relief. So it's really remarkable. So we happen to be in a place where where number wise, you'd say, oh, wow, you know how when you do quality measures in health centers and you say, oh, well, we should be at 90% and we're at 10%. Well, that's great. It's easy to make improvement versus being at 80% and trying to get 90%. So we're in a position to make a huge difference. It's just a really, really hard uphill push, which is why I really appreciate Dr. Weissman's slide. And I really appreciate that you added misinformation and communication strategies. And to immediately flip gears, for me, these echoes are also science literacy education for those of us out in the field. There was one, and so Dr. Weissman, I'd like to come back to one of your slides because it was scientifically challenging for my science literacy, and I suspect it might be for some of our others, including our RTs. It's kind of like middle school science class here, and actually my son teaches middle school science to 6th grade here. And it's this, and it has to do with looking at interpreting tables. And we frequently see those CDC slides and lecture slides, both from non-Speakers Bureau scientists and Speakers Bureau scientists. And it's the slide, it had 3 graphs on it, and it had the dotted blue lines and the dotted black lines. And I kind of zoned out when I looked at that. And I would like to ask if you would go back to that slide and take us through that a little bit more so we can be more literate.
So Elizabeth, can you put that back up again?
Yes, I can.
That's cool.
Which slide was that? Was it towards the end or?
It was about vaccine effectiveness.
Oh, yeah.
It's the one a couple back. That one there, 29.
So I would like, if possible, for 70 to 80% of us at the end of this talk to be able to teach this back.
All right. Well, there are 3 graphs here, what the graphs are is on the vertical axis, the up and down axis. That's incidence rate in the graph on the left, getting infected, and the graph in the middle, getting infection severe enough to be hospitalized, and in the right, getting infected severely enough to die from it. And on the horizontal axis is time, is May, June, July, right? And each point represents the data for that week. The blue line represents folks who are fully vaccinated. The black line represents folks who aren't fully vaccinated. In each of the graphs, the vertical blue line you see is when the incidence of Delta variant became more than 50% of cases, because Delta variant was going up during that period of time. As you can see in each of the graphs, so if you look on the far left-hand side, the folks who are fully vaccinated in blue have a much lower incidence rate of infection than the folks who aren't fully vaccinated in black. And then in the middle for hospitalization, it's the same thing. The folks who are fully vaccinated in blue have a much lower incidence rate than the folks who aren't fully vaccinated in black. And the same for deaths on the right. The blue line is a lot lower than the black line. And then if you just look in the period after Delta became 50% of cases, so to the right of the blue line in each of the graphs, there's a 4.6-fold reduction between the incidence rates in the black line and the incidence rates in the blue line, which is vaccinated. So 4.6-fold reduction in infection, 10.44-fold reduction in disease severe enough to cause hospitalization, 11.3-fold reduction in disease severe enough to cause death. And this is data that's derived from 13 US jurisdictions reporting to CDC. So that's basically it. So, you know, and it really pretty clearly there's a difference between folks who are vaccinated and folks who aren't.
Okay, so when people, thank you, Dr. Weissman. So when people look at this, does anybody have any problems with this? Does anybody see any room? I'm thinking now about, there's a really famous book called Graphical Presentation of Quantitative Data. And in it, there's a chapter about graphical excellence. And this meets several criteria for graphical excellence. One of them is the greatest amount of information in a single view with the least ink. And this presents a huge amount of information. There's about 6 or 8 variables here. But as a consumer of it and as a viewer, there's 1 or 2 things that threw me right away. And I'm wondering if anybody else had, if there was anything else about it that was hard for anybody else. Okay, so one of the things that hit me right off, Dr. Weissman, was that the black line is going up, and right at the top of the column where the black line goes up, it talks about a reduction. It says 4.6-fold reduction, 10.4-fold reduction, 11.3-fold reduction, and I'm looking at that with more education than a coal miner, and there's something about that jars me, and because I see the black lines going up, even if I got the idea that that's COVID incidence in unvaccinated people. So I found that a little challenging, but I don't know how you would do it better. So that was one thing that struck me. And there's a calculation, there's math behind that 4.6-fold reduction that involves about 3 steps. So I still think it's a great graph, but that was a hard one for me. And then I'm curious if anybody, and Lisa, if nobody, oh, Lisa's gone. Oh no, Lisa's still there. I'm curious if anybody looking at this graph would take a shot at what is the exact date of the vertical blue line. And Mitra and Elizabeth, you're in this one too.
I know. Sometime in, I think it's
for us 7th graders, it involves interpreting these tables and graphs. You know, like what would you say is the exact? So you have to actually think about it. What's the exact date of the vertical blue line, and is it the same on all 3 graphs?
It might be like 4th of July or that weekend, maybe something.
Is that Mary?
Yeah, it looks like maybe early July, 4th of July weekend or something like that, maybe.
I haven't even made my guess yet. Anybody else have a guess? And imagine that there's a $50 gift card for the person who's the closest.
Oh my gosh. Okay, now we're talking.
Yeah,
now we're
like
talking.
Bob Barker rules, the closest without going over.
Yeah.
June 20th.
Well, in this case, you can't. In this case, you can't go over because it's a linear time scale.
Yeah.
June 25th.
Yeah, I say June 20th. Yeah.
Okay, great. So that's the point. That's a whole other thing. And even knowing what that vertical line was, So anyway, enough on that, unless you want to, anybody else wants to. Oh, the other thing is that the vertical scales on the left have different units for each graph. So it's beautiful, but it takes some time to digest. And it'd be a good, it'd be a good AP, high school AP science question, science exam question.
Well, the scales make sense because there are more infections than there are hospitalizations, and there are more hospitalizations than there are deaths, right? So.
Right. Yeah. Right. But it takes time to yeah, blah blah. I've made my point.
Yeah. No, I think, yeah, overall, it is showing us the differences of being vaccinated versus not. And I do think we can, hopefully build confidence in those that are still unsure. But I do think there's still going to be a population that it'll, even with the deaths that have happened, for younger populations or healthy individuals, I think it's still going to be a challenge for some people to come across that way on the side of vaccination. I think we can get some people on that side, but as Dr. Doyle, it's also geographic. When I was in Boston, like here in California, I visited Boston and it was not an issue. Everybody was wearing masks, even outside if it was like a lot of people around each other. So it's just it's interesting to kind of like look at that and understand it. But we appreciate that. That's a really great graph and it's really informative. Does anybody else have any comments or questions before we close out? You can always email us and join the COVID session too that we have upcoming. But other than that, I just have one announcement to make, and that our next session is December 6th with Robert Stansberry, and he's going to be doing central versus obstructive sleep apnea. And so we won't see you till after Thanksgiving. If you celebrate that holiday, please have a great time. And if not, just enjoy your time off. Other than that, I hope everyone has a great week. Thank you.